So welcome back to our part 2 of hypoglycemia presentation. Today we will discuss the signs and symptoms and how to recognize hypoglycemia. So signs and symptoms can be divided into two categories. Neurogenic or autonomic symptoms of hypoglycemia arise from activation of sympathetic nervous system and include sweating, tremors, palpitations, anxiety, and hunger. These represent the body's earliest warning signals. In contrast, neuroglycopenic symptoms results from inadequate glucose delivery to the brain, manifesting as confusion, visual disturbances, slurred speech, seizure, and even loss of consciousness. Neurogenic symptoms are typically early and reversible, whereas neuroglycopenic symptoms indicates advanced, potentially life-threatening hypoglycemia. Now, neurogenic symptoms of hypoglycemia can be subdivided into two distinct groups. Adrenergic signs are driven by catecholamines such as epinephrine and norepinephrine. These present as tremors, palpitation, heightened arousal, anxiety, and classic fight or flight responses. In contrast, cholinergic signs are mediated by acetylcholine. This includes sweating, hunger, and tingling sensation, which serves as additional warning signals. Together, adrenergic and cholinergic manifestations form the body's early warning system, alerting patient before neuroglycopenic symptoms develop. Now, this table distinguishes between the two major types of hypoglycemia symptoms, neurogenic or autonomic. They are the body's earliest alarm signals triggers by autonomic activation. This includes again tremors, palpitation, anxiety, sweating, hunger, and they typically appear early as glucose begins to fall. In contrast, neuroglycopenic symptoms reflects the brain glucose deficit. These occur later and are more dangerous, presenting as confusion, behavioral changes, visual disturbances, weakness, seizure, and even coma. Now, clinically, recognizing the shift from early autonomic alarm to later neuroglycopenic effects is critical for timely intervention. Now you can see autonomic symptoms of hypoglycemia come from adrenergic and cholinergic activation, serving as the body's early alarms. Neuroglycopenic symptoms on your right arise later from the brain glucose deprivation causing cognitive dysfunction. So awareness of falling glucose depends first on this body's alarm. When they are lost, they may lead to hypoglycemia unawareness. The risk shift to more severe silent neuroglycopenic hypoglycemia. Again, just to emphasize on your left, hypoglycemia awareness. When all these autonomic centers are intact, patients remain aware of their hypoglycemic episode. This is the hypoglycemia awareness. But when these neurogenic alarms fail, awareness is lost, leading to hypoglycemia or unawareness and a more serious and dangerous condition that is on your right. So let's now turn to the physiology of normal glucose counter-regulation. The body's built-in defense system designed to protect us from hypoglycemia. Now, when glucose falls, the body defends in layers. First, insulin secretion or endogenous insulin secretion is suppressed to prevent further decline. Next, glucagon from the alpha cell rapidly raises glucose through glycogen breakdown and gluconeogenesis. The third layer is the epinephrine that follows, boosting liver glucose and limiting its use by blocking uptake and insulin release. Finally, the last defense, cortisol and growth factor, provide delayed support, modestly enhancing gluconeogenesis and reducing utilization. Now, together, these defenses protect against dangerous hypoglycemia. The key points is that on your left, counter-regulatory defenses activates before symptoms of hypoglycemia are felt. Endogenous insulin secretion is suppressed first, followed quickly by glucagon and epinephrine release. Then cortisol and growth hormones rise later, providing delayed support. Glucagon is the primary defense while epinephrine becomes critical. If glucagon is deficient, together insulin, glucagon, and epinephrine form a core of hypoglycemia protection. But all three are impaired in diabetes, increasing patients' vulnerability. For the figure on the right, the glycemic threshold for hypoglycemia, as the blood glucose falls, the body activates defenses in a predictable sequence. Insulin suppression begins around 83 milligrams per deciliter, followed by glucagon and epinephrine release near 69 and 68 milligrams per deciliter. Growth hormone and cortisol rise later, below 66 milligrams per deciliter, but play a delayed, non-critical role. Now, symptoms emerge below 60 milligrams per deciliter with cognitive impairment and convulsion at deeper threshold. This glycemic cutoff guide both diagnosis and clinical response. Now, the pathophysiology of glucose counter-regulation in diabetes. For type 1 diabetes, the physiology of glucose counter-regulation is extensively impaired in patients with type 1 DM. As endogenous insulin secretion becomes completely deficient in type 1 DM, the first physiologic line of defense, modulation of endogenous insulin, becomes lost. As the plasma glucose concentration falls, insulin levels do not decrease. In addition, the rise in glucagon secretion, which is the second line of defense, is lost as glucose level decline. This is an acquired defect, but it develops early in the course of type 1 DM. Now, the counter-regulatory adaptation across the course of type 2 diabetes. In early type 2 DM, counter-regulatory defenses remain mostly intact with preserved epinephrine and only mild glucagon reduction. Hormonal release occurs at higher glucose threshold, providing partial protection against hypoglycemia. Insulin resistant in type 2 DM during hypoglycemia, epinephrine lipolytic effects predominate, elevating plasma free fatty acids. Epinephrine also stimulates renal glucose release, providing added protection. These features not seen in type 1 diabetes. In type 2 DM progression, as pancreatic insulin secretion decline, the glucagon response weakens, increasing vulnerability to hypoglycemia. And in type 2 DM, in aging patient or in older patient, hypoglycemia symptoms are blunted and recovery is slower. The counter-regulatory responses, epinephrine as well as glucagon, occurs later and with a reduced strength, while declining insulin clearance further heightens hypoglycemia risk. In healthy individual, falling glucose triggers a coordinated hormonal response with endogenous insulin drops, while glucagon, epinephrine, growth hormone, and ACTH, all counter-regulatory hormone rise. These drive glucose production in the liver, mobilize free fatty acids, and reduce muscle glucose uptake, restoring normoglycemia. In type 1 DM, absolute insulin deficiency eliminates the normal fall in insulin during hypoglycemia that signals alpha cells to release glucagon. Without this intra-islet cue, glucagon secretion does not rise as glucose drops, leaving patient highly vulnerable to hypoglycemia. In the long-standing type 2 diabetes, the glucagon response progressively weakens as endogenous insulin secretion decline, impairing recovery from hypoglycemia. So, who are at risk for hypoglycemia? The most at risk for hypoglycemia includes patients with type 1 diabetes and insulin-treated type 2 diabetes, as well as those taking an oral agent that stimulate endogenous insulin secretion like sulfonylureas. Risk is higher in people with a history of severe or recurrent episodes, long-standing diabetes with defective defenses, and lifestyle factors like skipping meals frequently, exercise, especially intensive exercise, or frequent alcohol intake. Certain medical conditions such as insulinoma, liver, and kidney disease also increase vulnerability. Patients at greater risk of hypoglycemia include those with diabetes on insulin or sulfonylureas with prior severe episodes, long-standing disease, lifestyle triggers, or certain medical conditions. Now let's compare how hypoglycemia affects patients with type 1 versus type 2 diabetes. In type 1 diabetes, hypoglycemia is frequent and often severe with impaired counter-regulatory responses like glucagon and epinephrine. These patients are more prone to hypoglycemia unawareness, and the cognitive risks such as confusion, seizures, and even coma are significant. Psychologically, fear of loss can reduce quality of life and limits insulin intensification. In type 2 DM, hypoglycemia is less common early on but becomes more likely with insulin or sulfonylureas use, especially in older patients. Counter-regulation may preserve initially but weakens over time. Severe episodes can lead to falls, cardiac events, and hospitalization. Like in type 1, fear of hypoglycemia can lead to relaxed glycemic target, compromising long-term outcome. Now, across both types, repeated episodes increase the risk of hypoglycemia unawareness, and the emotional burden can affect adherence and safety. These differences highlight the need for tailored prevention strategies in each group. So with that, I bring to a close to part 2 of our series. Coming up in part 3, we'll explore hypoglycemia unawareness, its underlying pathophysiology and causes. So thank you again for listening.